І мені звук. Є? Звук в мене. Добрий вечір. Я сподіваюся, що всі мене чують. Пані Оксана, ви мене чуєте? Чуєте, пані Оксана?
Вітаю, пані Катерино. Чую вас. Все добре, я тут. Я в українському каналі. Я вас чую, я в українському каналі.
Добре. І професор Крістоф, ви мене чуєте? Добре. Тоді ми починаємо. Пані Оксана, будь ласка, відкривайте, бо пан Йорг Фегер до нас не приєднається, йому треба було кудись бігти, тому ми починаємо без нього сьогодні.
Все, стартуємо, так?
Так, з вас. Стартуємо з вас. Дякую.
Окей. Вечір добрий, шановна фахова спільнота. Лікарі і немедичні психологи. Всі ті, кого цікавить тема спеціалізованих послуг для дітей та підлітків в сфері ментального здоров'я. Я сьогодні маю привітати вас з тим, що ми маємо невеличкий з вами ювілей. Сьогодні 10-та зустріч, 10-й вебінар, який ми спільно з ЮНІСЕФ в межах Всеукраїнської програми ментального здоров'я «Ти як» ініціативи першої леді України Олени Зеленської, і за підтримки і організаційної, і натхненної, і в тому числі за підтримки, яку організовує фахову спільноту міжнародних відомих експертів для України, від президента Європейського товариства дитячої та підліткової психіатрії професор Йорг Фегер. Тож, 10-й вебінар, на якому, як не дивно, знову велика кількість учасників. Нагадаю, що минулого разу у нас було більше 500 учасників, і нагадаю, що всі вебінари можна потім в записі придивитися на YouTube-каналі і Координаційного центру, і ЮНІСЕФ, і каналі особисто експертки, медичної експертки Дитячого фонду ООН ЮНІСЕФ Катерини Булавіної. Пані Катерина, вітаю, дякую вам за наше партнерство в тому, щоб поширювалися знання, яких потребує українська фахова спільнота. Всім сьогодні натхнення. Дякую. Стартуємо.
Дуже дякую, пані Оксана. Сподіваюся, що мене добре всім чутно. В мене таке прохання. Будь ласка, не пишіть своїх емейлів в коментарях тут. Буде простір, де ви будете писати свої емейли для отримання сертифікатів. В чатик ви пишете тільки питання. Все, що стосується сертифікатів, ви побачите потім в окремій розсилці, там, де ви вносите свої емейли. Питання вітаються, скільки у вас їх є, стільки будете потім задавати. Я буду їх зачитувати, перекладачі будуть їх перекладати, і професор Christoph Correll буде на них відповідати тоді, коли буде на цей час в кінці його презентації. І так, ми вітаємо професора Крістофа Коррелла, директора відділу дитячої та підліткової психіатрії, психосоматичної медицини та психотерапії Charité в Берліні. І дуже йому вдячні, що він погодився виступати на цьому вебінарі в свій неробочий час для української спільноти. Будь ласка, тоді наша команда виводить професора на екран з його презентацією, і ми починаємо.
Well, I was told that you tell me how much time I have.
Якщо ви мене чуєте, у вас є стільки часу, скільки вам потрібно. В нас зазвичай іде презентація десь 1 годину, іноді година 20, година 30. А потім, якщо у вас є час і енергія, люди зазвичай задають питання. Тому час у вас є.
But what amount of time have the people who are watching? I mean, is it an hour and a half? Because we're late already, 20 minutes. Do I need to finish by the top of the hour, or do we have an hour and a half? I need to serve
У вас
the
є
needs of
час
the
30
audience.
точно. Ви можете не поспішати. У вас є час. У вас є час 30
All right, thank
точно,
you.
може і більше.
Wonderful. That's an answer. Beautiful. So welcome, everyone. I'm so glad that you're all here and that we can talk about efficacy and safety of antipsychotics in children and adolescents with severe mental disorders. Let me start with my disclosure information. As you can see, I'm fortunate to work with a number of organizations that are fortunately still developing medications for the brain. Many had left. It's very important that the pharmaceutical industry does these studies, and not only in adults, but also in children and adolescents. We have a big program tonight in order to get through all of these disorders where atypical antipsychotics have approval. We'll talk about unapproved options only during the question and answer session. So I'll go with you through schizophrenia, bipolar disorder, autism spectrum disorders and aggression spectrum disorders, tic or Tourette's disorder as the efficacies. And then we'll also talk about the flip side of efficacy, and that is obviously tolerability. And here, children and adolescents often have more vulnerability. Therefore, we'll touch upon the main antipsychotic-related side effects. In order to improve outcomes, we also need to talk about monitoring. But first, I want to talk about the term of antipsychotic. We actually try to get away from the name of medications for an indication. Because when you give an antidepressant for anxiety or an antipsychotic for depression, that is very confusing to people. Therefore, we want to be neuroscience-based with nomenclature. And we as a group put together names that are based on pharmacology. And now many journals actually asked authors to not call these medications antipsychotics or antidepressants, but rather by their pharmacology. And the way we understand typical antipsychotics, first generation, they are predominantly dopamine receptor antagonists. Atypical or second generation antipsychotics have a second receptor system that we believe may be related to efficacy or at least reducing side effect problems. And that is serotonin 5-HT2A blockade. So they are serotonin dopamine antagonists. And as we will learn more about antipsychotics, we will learn also how to call them differently. As a point in fact, the most recent treatment approved in the United States for the treatment of schizophrenia is not called an antipsychotic. It's named by its mechanism of action. And that is a muscarinic M1, M4 agonist that can treat psychosis, but it can also treat other conditions in the future, as our dopamine antagonists or serotonin dopamine antagonists treat different conditions. So it's important to bear that in mind so that we don't confuse patients and families when giving the so-called antipsychotics for conditions outside of psychosis. But let's start with the first condition where these medications were tested and that gave them the name antipsychotic. And that is giving the medications for patients with schizophrenia or primary psychotic disorders. And there are multiple studies that were conducted against placebo that have shown us that yes, these medications, postsynaptic dopamine blockers, are effective for schizophrenia, even in adolescents aged 13 to 17. These studies were generally 6 weeks in duration. And in the beginning, they were flexible dosed. I list here the trials in the order in that they were conducted. But the FDA then asked for fixed dose studies. And you can see that the placebo effect in gray varies quite widely, but overall, the treatment beats placebo. There are 2 exceptions, or actually 3 exceptions, where this is not the case. And in these studies, the investigators didn't dose the patients with schizophrenia who are adolescents the same as adults. They actually did weight-based dosing. So for example, in the Prazodone, people who are less than 45 kilograms only got up to 80 milligrams. Or with a Cenepine, where adults get 10 or 20 milligrams, here it was 5 or 10 milligrams. And only the adult 10 milligram dose would have separated. So the lesson is, do not dose antipsychotics, dopamine blockers based on body weight. It's meaningless. We don't give twice the dose for a 140 kilogram adult than for a 70 kilogram adult. When dosing anything for children and adolescents, including dopamine blockers, there are only 2 ways to dose them. It's either wow or ow. You either see efficacy and then you stop even at lower doses, or you don't see efficacy, so you slowly go up and you're only stopping when there are side effects. There is no milligram per kilogram approach that may be applicable for stimulants. But when you do this, you also have to start low, go slow, but go. Meaning, yes, children and adolescents are more sensitive, especially when they are first episode or treatment naive patients. They're more sensitive to side effects. So we need to start low, but we need to also increase the dose until we find the right dose. Do not underdose children and adolescents. Small people don't always need small doses. That is very important. So we then meta-analyzed the effect sizes of the antipsychotics in adolescents with schizophrenia and showed roughly overlapping effect sizes with the adult literature for acutely exacerbated patients. This is the red numbers to the right. The only exception where there was more efficacy in children was with more sedating medications, olanzapine and quetiapine, which may be that we're counting sedation as if it was an antipsychotic effect. And there was an unusual negative finding for ziprasidone, lower effect size than in adults, but that's most likely due to problems with underdosing due to weight. But also there were sites and countries where there was not enough drug exposure. Patients didn't take the medication. So the lesson learned is that our dopamine antagonists and partial agonists work as well for schizophrenia in adolescents as they work in adults. We don't have developmentally reduced efficacy for dopamine antagonists and partial agonists in youth. Very important message. And we shouldn't dose them based on weight, but you go slow until you find the right dose for the right patient. There are very, very few studies that looked at treatment-naive patients that have never been exposed to antipsychotics against placebo. This actually is the first study ever conducted that included treatment-naive adolescents. And what we found was that in those patients that are more common in child psychiatry, where we often have patients start at the beginning of the treatment journey, that the effect sizes are larger. So we can expect at a group level better efficacy than in people who are pre-treated. So you can see that an effect size of 0.5 is medium and 0.8 is large. That's 80% standard deviation difference between two treatments. And our overall effect size for antipsychotics in adults is 0.4. And that's the same in previously treated patients on the right, 0.45. But when you look at antipsychotic naive patients, it's almost double. So we have the chances in naive patients to have good efficacy. On the flip side, we also have earlier onset of schizophrenia, which brings with it a larger subgroup of people who are treatment resistant and who will not respond to first-line agents. So we need to also learn and know about clozapine, because the neurodevelopmental subtype of schizophrenia, patients who have difficulty with walking and talking, social adaptation early on, are more likely to not respond to postsynaptic dopamine blockade. And for those, we need to also know about clozapine. There are very few head-to-head studies. They are mostly very small. The studies before were all placebo-controlled. And in head-to-head studies, the only drug that really separates from other antipsychotics is clozapine, like in adults. So for treatment-resistant patients who have at least had 2 trials that were failed for efficacy of a duration of at least 6 weeks and at least a medium dose in the approved dose range, we should consider clozapine. There are 2 larger head-to-head studies showing again no difference. Here, paliperidone, a full antagonist, versus aripiprazole, a partial D2 agonist, and both agents are equally efficacious for total symptoms, positive and negative symptoms. This is a study we conducted in Denmark, comparing aripiprazole now with a weaker postsynaptic dopamine binding agent, quetiapine extended release, and again, in terms of efficacy, no difference. So that means that in the treatment algorithm, you should most likely start with the lowest side effect laden drug. So start with an agent that has the least side effects. If that doesn't work, move up to one that has more side effects, and then ultimately maybe reach clozapine. So I follow the AROC principle: aripiprazole, risperidone, olanzapine, clozapine. So I give a third medication before going to clozapine, because patients may actually respond to olanzapine, which has a lot of cardiometabolic side effects, as we will see, but it's easier to tolerate than clozapine. There's only one single placebo-controlled maintenance study in adolescents with schizophrenia, showing, like in adults, in this case with aripiprazole, that there is better efficacy staying on the drug than stopping. So if someone really has schizophrenia, most likely the medication needs to be given lifelong. But I'm showing this also to you to make sure that you do not underdose antipsychotics. 10 milligrams of aripiprazole is the minimum antipsychotic dose. You can go up to 30 in patients who are not responding well. Here, before the placebo-controlled discontinuation, there was an open stabilization phase. And clinicians either dosed patients based on their efficacy at 10 to 15 milligrams or 20 to 30 milligrams. And when calculating the number needed to treat, which is how many patients do you expose to treatment until you get one better outcome than placebo, you want the lower number being better outcome. And you can see that in the higher dose, 20 to 30 milligrams, after each fourth patient, you prevent one relapse. Whereas at the lower dose, 10 to 15 milligrams, it takes 11 patients. Again, a plea to not underdose dopamine blockers and partial agonists in patients with schizophrenia, unless obviously they have side effects that limit your dosing. This is the approval age for different dopamine antagonists and partial agonists. Brexpiprazole now will also soon be approved in Europe. It is approved by extension now also in the United States based on 13 years of age. Let's move on from schizophrenia to bipolar disorder, a condition where atypical antipsychotics or serotonin dopamine antagonists are approved in adults not only for mania and prevention of mania, but also for bipolar depression and prevention of relapse of depression. In pediatric bipolar disorder, we only have approval for mania, not for bipolar depression. We also don't have approval of serotonin dopamine antagonists as augmentation for unipolar depression in people who are partial responders to SSRIs. So we don't have any evidence in kids whether this works or not, although these agents are approved in adults for both bipolar depression and unipolar depression and augmentation. Let's look at the data for mania. So here you can see that all agents and all doses were significantly better than placebo, different from schizophrenia. Here patients are not 13 to 17, they're 10 to 17 years old. The studies do not need to last 6 weeks like in schizophrenia. They last 3 or 4 weeks. That means that dopamine blockade and partial agonism is more efficacious to treat mania than schizophrenia or psychosis. So even though we call them antipsychotics, they're better anti-manic than antipsychotic agents. And the same is true also in adults. So here, every dose works quite nicely and faster than for schizophrenia. But that is for mania only. Different from adults, mood stabilizers that do work in adults similarly in monotherapy as dopamine antagonists have almost no efficacy. Valproic acid, oxcarbazepine, topiramate, lithium even, very poor data. There are only 2 studies where there is some efficacy. So it seems that ion channel modulation that antiepileptics and lithium give are not as efficacious to treat mania in youth than they are in adults. But that brings then the question whether this is true also head-to-head, because studies in people who got antipsychotics may have had different patients than studies that used mood stabilizers. in placebo-controlled trials. So here you see a meta-analysis showing that in patients, children, adolescents, the effect size for antipsychotics was 0.6, but it was very small, 0.2, 0.24 for mood stabilizers. But again, this is not in the same study. This is maybe in different populations. So looking at now studies where patients were either randomized to an antipsychotic or a mood stabilizer, we see again head-to-head that the dopamine blockade or modulation works better for mania than anti-epileptic or even lithium treatment does. That is both on the left-hand side for treatment response and on the right-hand side for remission. We then have a paper here that looks at which symptoms drive that advantage of antipsychotics. Could it be that we're just treating psychosis or agitation? But here you see effect sizes going up, favoring risperidone in comparison to lithium in the team study. And you can see that not a single item on the Young Mania Rating Scale favors lithium. That would be when the bar would go downwards. Everything is in favor of risperidone as the antagonist. Some of the symptoms are only changed with a small effect size, 0.2. That's the yellow line I drew. But there are others that have even medium effect sizes. That's the overall score. It is irritability and anger, but also goal-directed activity, grandiosity, flight of ideas. So here we seem to have a developmentally driven, better outcome with dopamine modulation than with ion channel modulation that we get with either antiepileptics or with lithium. We have then meta-analyzed all of these studies together, head-to-head, as well as studies that looked at placebo control, and show yet again that antipsychotics have better efficacy, either for symptom reduction at the top or for response at the bottom, whereas even lithium and antiepileptics for the acute manic episode do not seem to work as well. We have no data to compare atypical antipsychotics and lithium for maintenance treatment, where lithium may actually shine because it takes longer to build up and maybe unfold its full efficacy. So I still use lithium in the mix for relapse prevention in youth quite a bit. But as I mentioned, even though serotonin dopamine antagonists, partial agonists in adults are approved for mania, for bipolar depression, there are no good data in youth, partly due to a big placebo effect. Because in youth, depression is determined by many different things, including the environment. So this is a small study comparing quetiapine with placebo. But then there was also the study with OFC. I mean, this is the only study that was positive. But here we have olanzapine plus fluoxetine. And the antidepressant may actually have the effect. It's not necessarily olanzapine that drives it. There's one study and one medication that is approved for bipolar depression, but you may not have it available, and that is lurazidone. So one single treatment for bipolar depression does exist for kids as early as week 2, Lurasidone better than placebo, and that was at 40, 20, 60, or 80 milligrams. Lamotrigine is a mood stabilizer that doesn't work well in the acute episodes for depression, but it can potentially prevent relapses. Overall, it's not approved because in the study of 10 to 17-year-olds, it just missed significance with a p-value of 0.07. When you then separate it into adolescents on the right bottom and children at the left bottom, you can see that lamotrigine doesn't seem to work for children, but it does prevent relapse in adolescents, even though this is a subgroup that has less power. So, as a treatment for maintenance in adolescence, you can consider lamotrigine, even though it may be off-label in your country. And this is a study where we looked at aripiprazole maintenance treatment for prevention of mania or depression, and at least in the last observation carried forward analysis, continuing this medication in monotherapy was better than stopping it. So again, if you're really sure that this is bipolar disorder, then most likely continuation of treatment is relevant. Another area where dopamine blockade or partial agonism works is for aggression. You know that from haloperidol in the emergency room for adults. But we do not want to use first-generation antipsychotics at high doses in adolescents with agitation because they are more sensitive to dopamine blockade and related neuromotor side effects. When thinking about aggression in children and adolescents, we need to follow the Texas algorithm. Meaning, when there is ADHD, attention deficit hyperactivity disorder, where you don't have enough frontal lobe control over your cognition, but also affect and behavior, you should not treat aggression with an antipsychotic first. You need to first treat ADHD. Get the brain of these patients under control of their cognitive, executive, affective, and also behavioral capacity. Only after you've treated ADHD well, in these ADHD plus patients, they have ADHD plus aggression, ADHD plus oppositional defiant disorder. Only after you've treated ADHD well, and there's still remaining aggression, should you then consider an antipsychotic as co-treatment. Obviously, patients who do not have ADHD, there you could also, in patients with autism that have other reasons for discontrol, you could start an atypical antipsychotic. When looking at pharmacologic treatments for aggression in youth, this is any aggression, not just autism related, it seems that antipsychotics, dopamine blockade, like for mania, work better than mood stabilizers. Full dopamine blockade works with risperidone, 0.7 effect size, haloperidol, 0.8, old studies, all in patients. And with aripiprazole, it is a dose effect. Do not underdose partial agonists. Higher doses mean more antagonism. So the 0.79 effect size, which is very nice and close or even higher than risperidone, was in the flexible dose study where people could find the right dose. But you also see here that stimulants work for aggression, and that is in patients with ADHD, where the ADHD needs to be treated first. It looks as if the effect size for methylphenidate is better than for amphetamine, but this is an artifact due to the shorter duration of treatment with the amphetamine studies, 3.5 weeks, compared to the longer treatment with more time to get better effects, 6.6 weeks with methylphenidate. But you can see that at least valproic acid and carbamazepine do not seem to be viable agents for aggression in youth, whereas lithium may be, yet these were in patients where you have also more room for improvement. The other studies, except for haloperidol, were all ambulatory care studies. This is an important study conducted by Joe Blader, NIMH funded by the National Institute of Mental Health, where he wanted to compare risperidone with valproic acid for kids with ADHD and aggression. But the National Institute of Mental Health said, we are not funding anything where young people get an antipsychotic unless you have given the families some parent training, behavioral regulation of the aggression in people who have no low IQ, who have no autism spectrum disorder, who have ADHD and aggression, which by the fact is the largest group in the United States that gets antipsychotics in children and adolescents. It is not people with schizophrenia, youngsters. It's not people with bipolar disorder. It's not autism. It is ADHD plus. And here's the finding. The families that came, nothing works outside. We've tried everything. Some even were on antipsychotics in the past. 63%, 2 out of 3, remitted from the aggression by optimizing the stimulant treatment and giving parents a very basic parent training contingency plan. Don't give in to everything, set limits. So that means for the remaining RCT, there were very few patients left. But still, despite that, risperidone was significantly better than valproex, showing again that dopamine blockade is better than antiepileptic treatment. The reason why antipsychotics or dopamine blockers started to be used more in child psychiatry is this study, the RUP study that is now 23 years old. Because in 101 patients, mean age below 9, 8 weeks of risperidone with a mean dose of 1.8 milligrams successfully treated 69% of patients. They were responders on the aberrant behavioral checklist, irritability subscore. That a 25% reduction and were much or very much improved on the clinical global impression scale. In contrast, placebo patients only 12% improved. This is a number needed to treat of 2. After each second patient getting risperidone, you had 1 full responder. These effect sizes are almost unheard of in medicine. That is in the acute setting. Patients were then followed for 6 months on open label treatment, and patients who were responders on risperidone either stayed on risperidone or went to placebo. And you can see here that almost 90% of patients remained responders on drug and that was only true for 37.5%. Subtracting 37.5 from 87.5, the difference is 50%, meaning for relapse prevention, just 8 weeks continuing versus stopping, it was again a number needed to treat of 2. So these are enormous numbers to get patients stable. We're not treating the autism core disorder, but we're allowing them to receive psychosocial treatments, go back to school, and function. So here, that gives birth to dopamine blockers being used much more in child psychiatry. In addition to the approval of risperidone for autism spectrum disorders in the United States, there's also approval for aripiprazole with separation as early as week 1. And in the flexible dose study, also an effect that was at least as good as for risperidone. What's interesting is that when you treat patients not with autism, but with sub-average IQ and disruptive behavior disorder, again, in this case, risperidone works, and it works very fast. So when you want to do parent training and psychotherapy, it takes weeks to get a spot. It might not even be available where the patient lives. But here, after 3 weeks, the full effect is seen. That can help patients go back to school, not get into trouble at home or with peers, develop a different self-esteem and self-image. So that's why these treatments can be quite life-saving given in acute crises. The question, though, is, once you've given this to patients who are not autistic, who may, with their stability, be able to take advantage of psychosocial, family and parent interventions, do you need to continue, or after the learning has taken place, could you potentially lower the dose or stop it? And this is the point, in fact, here. This is patients who have disruptive behavior disorder, not autism, and they either stay on treatment or they go to placebo after a stabilization phase. Remember, in autism, it was basically 8 weeks. That's 60 days. Here, we now have relapses in disruptive behavior disorder of 15% for risperidone, but only 30% on placebo. Whereas for autism, very similar, 12.5% relapse on ongoing risperidone, but at 8 weeks, 62% on placebo. So the number needed to treat here is 7, not 2. Meaning, if we go back, that here ultimately, quote unquote, only 30% of patients relapse. So that means 70%. This is on drug, but on patients, basically 60% will not relapse even on placebo. 6 out of 10, meaning once you've stabilized the patient with disruptive behavior disorder, learning and family interventions have taken place, you could very, very slowly try to reduce the medication. Whereas in autism, most likely not. Let's move to yet another disorder where dopamine blockade can be helpful, and that's Tourette's disorder. There are very few studies with dopamine blockers, and the only ones that actually led to approval are with aripiprazole. So there's one larger study where aripiprazole separated from placebo and reducing the TIC total score. And there's also, that's this study here, a Korean study showing TIC reduction as early as week 2 with a slight excursion at week 8. But the regulatory trial here also worked with both a lower and a higher dose. But you can see that also the higher dose, even with aripiprazole, was better than the lower dose. Here they used the weight-based dosing, which I'm again not a favor of, but you can see that you shouldn't stop at lower doses if there are still symptoms. Try to move as high as you can to get good efficacy while there is still stability and lack of rate-limiting side effects. That brings me to side effects as the second part of this presentation. We need to weigh efficacy with safety. And we need to do that because tolerability affects medication liking and adherence. And only when medications are taken and tolerated and not stopped can they work. And only when medication works for symptoms can we then also improve higher order outcomes, subjective well-being, quality of life, and functionality, being able to go back to school, having friends, being able to interact with the family. Now, there are no skills in pills. Medication alone doesn't give people school performance, friends, happy family life, but it enables them to have good social learning and take advantage of psychotherapy, family intervention, or psychoeducation. So symptom stability and relapse prevention are important, but tolerability is also needed for that. Let's start with the most classical side effects, neuromotor side effects: dystonia, Parkinsonism, akathisia, tardive dyskinesia. The feared side effects of too much postsynaptic dopamine blockade. And I'm showing you a study that is very old. It actually is 42 years old, but it shows why we are using atypical antipsychotics, because there is an age-dependent risk of Parkinsonism and dystonia. The 10 to 19-year-olds are much more vulnerable to develop Parkinsonism and dystonia. Over half have Parkinsonism, 2/3 develop dystonia. That is old data. Interestingly, that goes down with age, but also, interestingly, akathisia is not age-related. You don't have a higher risk of akathisia in children, showing us again that this is most likely not a postsynaptic dopamine blockade-related side effect. But because of this, we should be very, very careful using typical antipsychotics, especially Haldol, which is so hard to titrate to be without EPS. So rather, if you don't have atypical antipsychotics, maybe think about chlorpromazine or sulpiride or drugs, loxapine, that are not as tightly binding as haloperidol. This is a cohort study showing that we do not have higher extrapyramidal side effects in children and adolescents when they are dosed appropriately. This is a study we conducted in New York. So basically, the only outlier here is risperidone that can have somewhat higher discontinuation due to side effects. Otherwise, these drugs are very similar. Tardive dyskinesia risk is lower in children than in adults, simply because there is a bigger buffer. We have more dopamine receptors available in youth. We do not have yet cumulatively that many milligrams in the system. and usually the doses are also lower. But we don't know whether over time kids started early, especially those who do have extrapyramidal side effects and and akathisia, two risk factors for tardive dyskinesia, will not develop more tardive dyskinesia when they become adults. Very important, because in your settings, most likely you use more first-generation agents. Do not give anti-Parkinsonian medications long-term. You are masking extrapyramidal side effects, you are decreasing cognition, and you're increasing the risk of tardive dyskinesia. Rather, give the anticholinergic only a short period of time if you need to, because maybe the dose increased too fast. But if you can't lower the dose without EPS, you need to lower the antipsychotic dose, because there are no data to suggest that having extrapyramidal side effects is needed for efficacy. You need to be below that threshold. Sedation can be quite problematic because kids need to go to school. Kids need to take in the world. They need to still develop and thrive, get in information. What we showed in this study is that even medications that traditionally don't have much sedation, aripiprazole, risperidone, do cause sedation in kids. That's why I give all antipsychotics only at night, never in the morning. You want to sleep through the peak. The dose level is the same, but the blood level goes up after the dose. And you should give these medications once a day anyway. There are very few patients, if any, where aripiprazole should be given in the morning, or cariprazine. These are not caffeinated drugs. They can lead to insomnia or activation when you switch too quickly from a dopamine antagonist, because these are partial agonists. When you switch from a sedating drug and you do it too quickly, then you can get insomnia or agitation. But in monotherapy, generally, even aripiprazole is sedating. And the same is true for hypersomnia, where these drugs are very equal, although olanzapine obviously has a slightly higher effect there. Let's talk about prolactin. Prolactin is a side effect very, very vulnerable to postsynaptic dopamine blockade. And we do see that in people, particularly on risperidone. So here is a recent study we conducted. With risperidone, you very reliably see increase in prolactin levels. Olanzapine can do that too, but you see a reduction with quetiapine, and even more of a low level with a partial agonist, aripiprazole. In patients who need to be on haloperidol, need to be on risperidone, and you have high prolactin levels that are in the triple digit, 100, 200, 300 nanograms per deciliter, you can add aripiprazole, and then the prolactin level normalizes. 5, 10, 15 milligrams of olanzapine. But maybe you can even switch and you don't need the tight dopamine blockade. What we found in this study, though, is that it was interesting that sexual side effects did not correlate with hyperprolactinemia, although there were differences in hyperprolactinemia, as you can see here. The highest with risperidone, followed by olanzapine, a little bit on quetiapine, but almost nothing on aripiprazole. These are data not in children. I have only 2 slides in the whole presentation where these are data in adults. It just two studies we published a couple of years ago, that we see, unfortunately, that patients can potentially females develop breast cancer in the long run, prolactin elevation. Let's talk about cardiometabolic side effects. These are very feared, and we obviously have a gradation that's pretty clear. Olanzapine causes the most weight gain, followed by risperidone and quetiapine, and very little weight gain with aripiprazole and ziprasidone. But in treatment-naive patients, all of these medications can cause weight gain, including aripiprazole. And this is what we show here in a study, an open label study, that these are kilograms at 12 weeks, that even aripiprazole can cause 4.4 kilograms, similar to quetiapine or risperidone. Obviously, olanzapine has the highest effect on weight. And olanzapine is also the most pan-metabolic problem. It is the drug that makes all metabolic parameters worse, followed by quetiapine, whereas risperidone only increases triglyceride levels, and aripiprazole, despite the weight gain, was metabolically neutral. Looking at the number needed to harm, how many patients you expose until you have one person gain at least 7%, it is between 1 and 2 patients across these 4 medications. But once you want 14% weight gain, here aripiprazole is not significant anymore, but it's still 2 to 4 patients at 12 weeks. After each 2 to 4 patients, you have 14% weight gain. And if you look at 21% weight gain, which is obviously a fifth of the body weight after just 12 weeks, it's statistically significant after each 4th patient on olanzapine. So we have to be very careful with olanzapine and use that only as the second last resort before patients go to clozapine. Lurasidone didn't have any further weight gain compared to the generally expected weight gain when patients grow up. I don't know whether you have lurasidone, but that seems to be the safest in terms of weight neutrality. And lumateperon, which is only approved in the United States, also is weight neutral. Unfortunately, people who are on antipsychotics can also, when they're young, develop diabetes. So our patients are not free of that risk. We need to monitor for diabetes. Compared to healthy controls, the risk of diabetes is 2.5 to 3-fold higher. Compared to other psychiatric patients who are not on antipsychotics, the risk is still 2-fold higher, and particularly for olanzapine. We don't have time to go through all of the different side effects, but if you're interested, we wrote a paper in World Psychiatry where we went through all of the efficacy and all of the side effects in 2 different papers. But it just shows there's a lot of underreporting, unfortunately. And in this case here, lurasidone, again, seemed to have the lowest side effects profile, higher than placebo. There's one study where it seemed that mortality rates were dose-dependently higher in adults, that's at the bottom here, higher than 100 milligrams chlorpromazine equivalent over time increases the risk of mortality, but that was not the case in children and adolescents. But we just published a paper last month in World Psychiatry showing that when starting antipsychotics earlier in 6 to 17-year-olds, the risk of metabolic abnormalities is higher than when starting antipsychotics in 18 to 31-year-olds. Not absolutely higher. Older people always have more metabolic problems than younger people. Age is the effect. but relative to healthy controls, kids have relatively greater adverse cardiometabolic effects than adults, young adults. And even within the child component at the bottom, when you start an antipsychotic in 6 to 11-year-olds, the odds or the hazard ratio of a metabolic problem is 2.4 point high against healthy controls at that age, and it's only 1.7-fold higher than controls when you start at 12 to 17-year-olds. So in effect, be careful with long-term antipsychotic treatment unless you need it, and monitor weight and monitor metabolics. And this is the second paper only on adults, reminding you of a study we published also in World Psychiatry, that even doses of quetiapine of 50 milligrams and below, 50 and below, increases the risk of poor metabolic outcomes in adults greater than using Z drugs or SSRIs. So these medications, the penes, olanzapine, quetiapine, chlorpromazine, are not free of metabolic effects, even at very low doses. Let me finish up with a mandate to monitor side effects. We must do that. We need to get a personal and family history. Lifestyle monitoring. Are people eating well? Are they exercising? You need at each visit get height and weight because kids develop. Ask about somnolence, sexual side effects if you have adolescents. But then at baseline 3 months and every 6 months thereafter, we need fasting blood work to make sure that patients don't develop diabetes. Hemoglobin A1C can be helpful, or have poor blood lipids. Prolactin, I would only measure in medications that raise prolactin levels, so not partial agonists, especially risperidone, haloperidol, you need to measure it. And EKG only needed for ziprasidone, amisulpride, and clozapine. We don't have time to get through all of the thresholds, but here's a paper that we wrote looking at thresholds that are slightly different than in adults. Kids have a different way of calculating overweight and obesity, but also a different way of calculating whether they have hyperglycemia, whether they have hypertriglyceridemia, cholesterol abnormalities. It's similar for diabetes, but it's dissimilar for lipid levels. And that's at least something you should know and then monitor patients so that they don't get poor cardiometabolic health. What does that mean? Well, we should always start with the lowest risk agent first, as much as possible. Give healthy lifestyle instruction and counseling. If side effects occur, intensify level 1. Maybe switch to a lower risk agent. If you can't, then add something for weight control, maybe metformin, obviously healthy lifestyle. And if that fails, ask your pediatricians to work with you and the family to treat directly the diabetes, the hypertension, the dyslipidemia. There are do's and don'ts in healthy lifestyle. Sugar-containing drinks are bad. Even zero-calorie diet drinks are bad because sweetness tells the brain there's calories coming. So therefore, insulin stimulation takes place and insulin makes you hungry. So even though your drink is 0 calories that is sweet with a diet Coke, the next meal will be larger than if you had just had water or green tea. We need to eat slowly because the brain counts calories by chewing. When you have a thick broth, your appetite for the next meal is less than when you have a thin broth, and soups have more of a problem. Now we have the light is out. Sorry about that. Then when you have soups, you have less counted calories than when you would have a chewed food. And obviously, we want people to not watch television more than 2 hours and at least have 3-4 days a week where they have at least 30 minutes of exercise. So let me sum up to give us some time for the discussion. Second generation dopamine serotonin antagonists have proven efficacy in pediatric schizophrenia, bipolar mania, for lurazidone also in bipolar depression, irritability associated with autism, and also disruptive behavior disorders, as well as Tourette's. Like in adults, the relative efficacy differences are relatively small. Differences in side effects are much larger and more predictable. Additional efficacy based on open studies suggests that atypical antipsychotics could maybe be given in augmentation for obsessive compulsive disorder, major depressive disorder, hyperactivity associated with anorexia, but there are no good treatments that are placebo-controlled. We need to carefully weigh risks and benefits, and lower risk options should be tried first. Do not underdose these medications. Start low, go slow, but go, and reach either OW or WOW. Treat to efficacy and stop only when you get either efficacy or side effects. The ranking order of the side effects are roughly equal as in adults, with maybe more weight gain with risperidone in kids than in adults, maybe somewhat less weight gain with clozapine, more prolactin elevation with olanzapine and ziprasidone in kids than in adults, but all drugs have more sedation risk than in adults. Diabetes and metabolic syndrome are rare because kids still have a good pancreas to work with, but still it can happen. So you need to monitor it. You need to educate families about cardiometabolic risks, the need to have even better exercise because the medication will cause weight gain by appetite increase. We need to balance the efficacy with safety. Ask families to tell us when they feel the kid can't take the medication or becomes non-adherent. And long-acting injectables, even though not studied against placebo, should also be considered whenever possible in adolescents because there's a lot of problems with non-adherence, which can lead to pseudo-resistance. So clearly we need novel agents that are not dopamine blocking, and hopefully we will get that in the future. So let me thank you for your attention and looking forward to your questions.
Окей. Дуже дякуємо. І зараз будемо розбирати питання, які є. Перше питання від пані Віри Дзьобас. Якого віку були ваші наймолодші пацієнти? І як ви фіксуєте побочні ефекти препаратів, електронна чи паперова фіксація?
I need to relocate because my battery is out in a second, but I will answer as I relocate. Yeah, so I treat patients as of 5 years old, and sometimes, unfortunately, these children that are very active and hyperactive and agitated, I have given medication to 5-year-olds, but not younger than that. And it really depends on how we can best treat patients. And it's again the symptoms that dictate whether or not we need to treat them. In that sense, I think it depends on what you have as your target. So.
Professor Correll, you disappeared. Зараз почекаємо, поки професор приєднається до нас знов. Будь ласка, поки що пишіть ваші питання. І, будь ласка, не використовуйте скорочень, бо для перекладачів це буде важко. Тому пишіть повністю терміни без скорочень. Зараз почекаємо, що професор до нас доєднався, щоб відповісти на ваші запитання. Трішечки потерпіть, бо він переходив, як ви бачили, з машини кудись, тому чекаємо. Зараз чекаю сигналу від нашої команди, чи ми бачимо професора, чи ні. Шановні колеги, поки що вам скажу, що якщо у вас є хтось, хто ще не дивився цю серію, ми радимо передивлятись ці відео, вони є в Ютубі, в папочці на Ютуб-каналі доктор Булавінова. Зараз вам лінк в Zoom скинуть на цю папочку. І там є версії як англійські, так і українські. І ми іноді робимо вам розсилку з цими версіями в вашу електронну пошту, тому перевіряйте. Якщо у вас є побажання по темам, бо професор Фегерт, який нам допомагає організовувати весь цей цикл вебінарів з провідними європейськими професорами, професор Фегерт готовий далі продовжувати цю співпрацю, тому, будь ласка, пишіть нам як на пошту, так і в коменти. Також можете писати, наприклад, мені в Фейсбуці, в месенджер, яких тем ви хочете, про що вам цікаво, що для вас важливе. Наприклад, сьогодні я була на тренінгу з медичними працівниками з пологових будинків, і вони просили презентацію про післяпологову депресію в наших колег попросити. Може, у вас будуть якісь ще ідеї, про що вам важливе. Зараз ми перевіряємо, як в нас ситуація і чи зможе наш професор приєднатись назад. Якщо у вас є ще час, будь ласка, почекайте, бо завжди дуже цікаво в питаннях та відповідях буває. Поки ми чекаємо, зараз я своїй команди спитаю, ми не бачимо поки професора? Не бачимо. Поки ми чекаємо, щоб він приєднався до нас знову, розкажу вам ще, що є в нас на каналі, якщо, наприклад, ви зазвичай їм користуєтесь тільки для цієї серії. В нас доволі регулярно, десь раз на 2 місяці приходить до нас голова Національної служби здоров'я України. І ви можете, пані Наталія Гусака, ви можете в неї питати все, що захочете. І зазвичай це прям така серія питання-відповіді, бо дуже є багато питань від медичних працівників, і пані Наталія відповідає на них відверто і потім ще готує додаткові листи, роз'яснення з різних тем. В нас є на цьому каналі цикл про катамнестичне спостереження. Якщо ви задіяні в катамнестичне спостереження за тими дітьми, які народились з дуже маленькою або просто з маленькою вагою, то, будь ласка, дивіться цей цикл. Там є презентації як англійською, так і з перекладом. Також, якщо ви зареєструєтесь, можна здавати тести і отримувати також бали БПР після зданих тестів. Зараз я перевіряю, що в нас є якісь новини, чи я можу поки розповідати. Нема поки? Зараз ще трішечки почекаємо, може нам повезе. Також для тих, хто дивиться наш канал, дуже прошу звернути увагу на серію ефірів, яка в нас є з Генрі Маршем. Я думаю, що багато хто з вас читав книжки Генрі Марша, вони перекладені, вони в основному виходили в... ось професор нам відповів, професор Correll, що він працює над тим, щоб приєднатися, і тому ми чекаємо. Є? Виводьте його на екран, будь ласка. Зараз, чекайте. Так ось, поки виводять професора на екран, ще раз хочу вам порадити, щоб ви подивились всі ефіри з Генрі Маршем в нас на каналі, які є. Вони, знову ж таки, є англійською мовою та з перекладами. Також є дуже класний ефір, де Генрі Марш і Рейчел Кларк обговорюють питання паліативної допомоги.
I don't hear you yet well.
Зараз.
Hang on.
Ага, я не бачу професора, але я його чую. Перекладачі, чи вас чує професор, чи ви чуєте його? Ага, ось я бачу професора. Перекладачі, будь ласка, перевірте, чи професор вас чує.
I can now hear everything.
Добре. Тоді в попередньому питанні було питання про наймолодших пацієнтів, і професор відповів, що наймолодшій пацієнті 5 років. Друга частина цього питання була про те, як він фіксує побічні ефекти препаратів, чи це електронна фіксація, чи паперова фіксація.
I do this with paper and just asking questions.
Добре. Питання від пані Литвин Людмили. Чи доречно додавати антипсихотики при обсесивно-імпульсивному розладі підліткам, якщо сертралін в дозі 200 мг дає неповний ефект? І пацієнт з надлишковою вагою.
That's a great question. I would, if SSRIs don't work, first of all, sertraline maximum dose of 200 is for depression. You can go up to 300 for OCD, but the better treatment is most likely clomipramine. Clomipramine is the best anti-OCD, obsessive compulsive treatment that we have. I would first go to clomipramine, and if that fails, then you could augment with an antipsychotic, and I would usually use aripiprazole. Especially in someone who's obese.
Питання в нас таке. Якщо у дитини біполярний розлад, з якого віку варто давати луразидон?
So the studies were done 10 to 17-year-olds. But wait, now I hear Ukrainian. Yes. So it's 10 to 17 were the studies. However, I mean, if you have an 8-year-old, you might need to go off-label.
Пані Анастасія Ілто, ви даєте ліки для дітей, що менше 13 років, як off-label?
For schizophrenia, yes. For bipolar mania, no, because there the doses are 10 years and older. But in child psychiatry, we have to deal with what we have. And the studies that were not done in younger patients doesn't mean that these medications wouldn't work. So the alternative to not using off-label medication is to do nothing. And that's obviously even worse for patients. So you can try and see whether it works and whether it's safe.
Пані Наталія Петренко питає, скажіть, будь ласка, якому з препаратів респеридину чи оланзапіну ви особисто надаєте перевагу?
Well, I mean, it all depends on the indication, but I usually go safety first. So I start with aripiprazole, and only if that doesn't work, I might go to lurazidone. And if that doesn't work, I go to risperidone. But I clearly prefer risperidone over olanzapine, because olanzapine has so many cardiometabolic risks. that shortens lives. I do prefer olanzapine over clozapine. So if nothing works, then olanzapine is my last go-to drug. But I would certainly go first with risperidone before olanzapine. But I would go first with a lower risk agent, aripiprazole, cariprazine, lurazidone, before going to risperidone.
Пані Оксана Михайлюк питає, які покази до призначення метформіну для підлітків, які приймають антипсихотики? За яких умов його доцільно додавати до терапії?
Yeah, that's an excellent question. Metformin is not a wonder drug, but it can certainly reduce weight gain and can reduce weight after weight gain. It seems to be best in prevention of weight gain, meaning if you see someone who gains weight a lot in the first month, a kilo a week or half a kilo a week, early weight gain predicts later weight gain. That's the best predictor. Go in early to prevent further weight gain. If people have gained a lot of weight, losing weight is harder than gaining weight. So I would try to start it early as an augmentation of an antipsychotic. You need to do one thing before you start metformin. Test creatinine levels, because you need to have normal renal function, which in adolescents and children generally is the case. Creatinine needs to be less than 1.3. Then you start in kids that are less than 45 kilograms, 250 milligrams per week, and go up every week by 250. And in kids that are 45 kilograms and higher, you start at 500 milligrams per week, and you go up in divided doses. Start with a meal. With meals, you have less weight, you have less gastrointestinal side effects. Nausea, vomiting, flatulence, diarrhea are the 4 side effects, but giving it with food is easier. You start 500 in the morning 1 week, then 500 morning at night. And in kids that are 45 kilograms and higher, you go to 2 grams, 1,000 and 1,000. And in kids that are lower weight, you go to basically 750 milligrams. When you give metformin long term, you need to give a multivitamin with it, because there's a vitamin B12 malabsorption in the long run. So make sure that they get at least multivitamin with long-term metformin treatment. The better weight loss drug is certainly GLP-1 agonists, liraglutide, semaglutide, but those are once weekly in subcutaneous injections, and they're more expensive.
Пані Віра Дзьобас питає, чи застосовуєте ви у лікуванні немедикаментозні методи лікування?
Well, it depends obviously enormously what condition we're talking about, but for depression, I use CBT, absolutely. For OCD, I use CBT. For schizophrenia, I would use basically supportive psychotherapy and psychoeducation. I would use cognitive remediation treatment and supportive work and education. For mania, I would also use supportive psychotherapy, maybe social rhythm therapy. So psychosocial interventions are very important, absolutely. Family therapy to get everyone educated, adherence, that they understand this is needed. But I don't use supplements or anything like that. I would use exercise. Exercise is good for depression, negative symptoms, and physical health.
Пані Оксана Михайлюк питає, чи використовуєте ви шкалу ABC Irritability Score у своїй клінічній практиці для оцінки агресії? Якщо так, які показники ви вважаєте клінічно значущими для оцінки ефективності лікування?
Yeah, so measurement-based care is really important, but I don't use the ABC. I use basically a visual, the easiest is a visual analog scale from 0, no aggression, to 10, the most. You could also use basically the MOAS, the Modified Overt Aggression Rating Scale. That I do like because it gives you, over a period of either a week or since the last visit, different types of aggression: yelling, physical aggression against objects, physical aggression against others, and physical aggression against yourself. And then you can get the count, how many of such events have actually taken place. And you could also use a CGI of normal, borderline symptoms, mild, moderate, marked, severe. That could also give you like a measure of how much aggression there was. But usually in kids, it's the number of events.
Пані Людмила Федас питає, лікування синдрому Турета в поєднанні з розладом дефіциту уваги та гіперактивності. Які максимальні дози аріпіпразола для дитини 10 років?
Yes, so it's interesting that for Tourette's and ADHD, or Tourette's and aggression, there is not only the antipsychotic that works, it's also alpha-2 agonists. So clonidine or guanfacine would work for ADHD and also would work for tics. Obviously, the best treatment for ADHD is stimulants, but you could add for tics, not an antipsychotic, but maybe guanfacine, having dual treatment for ADHD and tics. But again, the dose and the age, the dose and the weight do not matter to me. It's wow or ow. If it's a 10-year-old, they may only tolerate 7.5 of aripiprazole, but they may tolerate 25 milligrams of aripiprazole. We don't know that. So you go until you see either efficacy or safety. One important point, if I may, aripiprazole is used a lot, risperidone is used a lot in kids. But beware that when you give fluoxetine or paroxetine, they are metabolized by the same cytochrome P450 system, 2D6. So basically, when you're adding fluoxetine to aripiprazole or risperidone, or you're adding aripiprazole, risperidone to fluoxetine, you're increasing the level of both medications, and the tolerability may go down. So lower the dose.
Угу. Зараз, секундочку, я перевіряю, що в нас тут з питаннями. Одну секундочку. Так, є питання від мами дитини, яка приєдналась до цього вебінару, пані Ольги Пеленської. Пані Ольга з міста Львова, вона мати дівчинки з ДЦП з спастичним тетрапарезом. До віку 12 років рівень інтелектуального розвитку дитини відповідав віку. Після 12 років почало спостерігатися відставання у розвитку на фоні стресу з повітряними тривогами. Є діагноз підозра на Турета, призначено галоперидол 0,1 мг і циклодол по півтаблетки. І є деградація в інтелектуальному розвитку. Чи може якось професор це прокоментувати? Ми його не чуємо, професор, ми вас не чуємо.
Yes, so I couldn't unmute myself. So basically, too much dopamine blockade is not good for the brain. So most likely haloperidol might not be the best treatment here. So you could either use guanfacine or clonidine for the tics that have no dopamine blockade, or consider aripiprazole or low-dose risperidone.
Пані Оксана Гайна питає, чи можна додавати транквілізатори до антипсихотиків у важких поведінкових дітей з порушенням сну у дітей з аутизмом?
Yeah, so in general, obviously, we want to avoid benzodiazepines. But if you have people with severe autism, where basically it's very hard to reason with them, they may be nonverbal, and they can't sleep at all, I would give whatever is needed to get sleep into the brain. So if you've tried other things, Z drugs, low-dose quetiapine, I would prefer quetiapine over benzos. Then you may have to use benzos. The problem with benzodiazepines is that they also reduce cognition. So that's why I might prefer trazodone, might prefer mirtazapine, might prefer quetiapine for sleep.
Увага перекладачів. Наступне запитання англійською мовою задали, тому я його зачитую англійською мовою. Пан Юрій Фільц питає, how to differentiate bipolar 2 disorder with ADHD, given that there are common symptoms in both hypomania and apathetic depression with ADHD presentation?
So, yes, there can be overlap, but what's the question? What does he want to treat?
Тоді перекладачі, будь ласка, може не перекладайте зараз, я зачитаю англійською, щоб професор почув це питання. Юрій Фільц is asking how to differentiate bipolar 2 disorder with ADHD, given that there are common symptoms in both hypomania and apathetic depression with ADHD presentation.
Yeah, I understand the overlap, but what's the question? How to treat it? I mean,
No, how to differ one from another, how
how to differentiate. Okay, I get it. I mean, ADHD has either inattention, hyperactivity, or impulsivity, and kids are maybe sometimes cranky, but they don't say they're depressed. Now, that would be the bipolar depression. If it's hypomania, then the question is that relevant for treatment? The apathetic depression wouldn't be an overlap with ADHD, only if you treat with stimulants and they have sometimes this blunting of affect. So I'm not clear what the question is, I have to say.
Окей. Пані Остапчук Вероніка питає, хлопчик 8 років, синдром Турета з обсесивно-компульсивним розладом, гіперактивністю, агресивною поведінкою. Яку першу лінію препаратів ви б рекомендували?
Yeah, so for the Tourette's and the aggression, and hyperactivity, this would all be treatable with dopamine blockade. But I would first treat the ADHD, because once the ADHD is under control, maybe there will be better motor control, there will be also better behavioral control. So first treat the ADHD, then see what's left over. If it is the Tourette's, you could either go with a alpha-2 agonist, ranfacine or clonidine, or with low-dose aripiprazole or risperidone, and then move your way up. And as you then improve the tics, you might also further improve the aggression.
Я бачу, що питань більше немає на сьогодні. Ми дуже вдячні вам, професор Correll, за цю презентацію і за те, що ви знайшли час в свій неробочий час, щоб нам це презентувати і відповідати на питання. Дуже-дуже вам дякуємо за ту підтримку, яку ви надаєте нашим спеціалістам. Шановні колеги, дуже дякуємо всім, хто до нас приєднався. Вас було багато, вас було десь 240-250 людей. на піці цього зуму. Ми будемо вам розсилати ці презентації як з перекладом, так і без перекладу, для того, щоб ви могли поділитися з тими колегами, хто не міг зробити цього в онлайні. Тому дякуємо ще раз професору Correll. Будемо закривати на цьому цей вебінар.
Thank you. All the best. Also in your situation.